Thanks very much, Michael, and thank you to the Scientific Committee for deeming this worthy to discuss, and thank you to the audience for being engaged and great questions so far, and thanks to my fellow speakers who have got great ways to solve common problems. I'd like to talk a little bit about a study that I thought really at our place at the Austin was a no-brainer. We really needed to be getting into the hearts and the minds of our junior doctors, and what better way than to get them while they're medical students. And I'd like to stress that I think that the strategy we used is applicable to medical students. It could have great applicability to nurse practitioners that are in training, or to crit care nurses that are in training, or to anyone that you really want to get involved in the Met. And you've got fabulous teachers in the Met. And so my acknowledgements here are to my co-authors, as well as the teachers here who really did the work, which was our Met nurses and our Met registrars, but really also acknowledging the key team members that do a hell of a lot of teaching are our Met patients and families. And so they were all really important contributors to making this work. So here we are at the beginning of the new medical year. So this could sum up the fear and abject horror experienced by patients, by staff, by Met nurses, by ward nurses, by consultants, but it absolutely is the fear felt by junior doctors in their starting out phase. And it's a really, really scary time. So what we set about doing was recognising that we worked in a system where we were trying really hard to get upstream of deterioration, that Met is getting upstream of code blue, but really we wanted to get upstream of roadblocks. I was fed up with having a really great teaching program for junior doctors that no one attended. And because we weren't paying them to attend teaching, they were paid to deliver clinical service. So instead we went to where the students were paying to learn, and they were motivated not just by money but by fear. And so that's a really important driver. And so we wanted to get upstream and get into the minds of our junior doctors while they were medical students. So really what we were trying to look at was, is it feasible to teach these guys? Can we boost their knowledge? And can we make them more confident in this final semester before they kick off being a doctor? So here's our intervention. It's a bit busy, I'm sorry. And effectively our intervention, it's a teaching one. So we did a baseline survey to work out what they knew and how confident they felt. And then really in red there is our educational intervention. I delivered a single lecture, just giving an overview of deterioration as well as what the program would involve. And then we had them in groups of 5 or 6 for a week at a time throughout the whole semester, and we gave them an opportunity, effectively a roster, where they had some time shadowing the Met, so just one student attached to the Met at any one time. They shadowed a role that we no longer have, but had at that time in 2014, which was the Crit Care Fellow. So we actually had a full fellow of the College of Intensive Care embedded in the surgical wards where it was really, really busy and lots of Mets were going off. We had them join us on the ICU ward round, and we had a whole lot of e-learning material and PowerPoint slides that we made available to them. Then at the conclusion of the week, we sat down for 2 hours and each student presented a case using a template that we'd provided with them, or using their own model if they wished to, and we discussed the issues that came up out of that. After that tutorial, we surveyed them again about knowledge and confidence, and then in the final stages, I tried and failed to survey them as interns. It was a complete waste of time. Although the comments were really nice, they really didn't help because there were so few of them. So we had 62 learners in the whole MD4 year, and virtually all of them attended throughout the whole week, and only a few couldn't make it to the tutorials. And we got a great response rate. So they were a captive audience in the lecture, and most chose to complete things. And they were great about returning their surveys at the end of the tutorial. And I've had to leave out, even though they were great responses, all 5 of them said lovely things. I don't think we can really use that in statistical analysis. So when we looked at them, what did they know? Well, they claimed not to have had a great deal of exposure to clinical deterioration teaching. Really, the only thing they could explain that they'd had was some BLS teaching. But it must have been good teaching, because in fact their knowledge was good and it didn't really get any better. They knew about who the staff were in their Met, they knew about calling criteria, and they knew what the triggers were, and they knew about the main Met syndromes, what it was that caused people to deteriorate. But confidence is where things really shifted. And we looked at 12 different domains, and whether we looked at whether they knew how to recognise what was going on, the responses that were required, or the team contributions. And really, it's scary to see how scared they were. The confidence was very low at baseline, and we made a massive improvement in virtually all areas. The one area we didn't was the confidence in setting up monitoring. But I think you'll agree that many of the other areas were very beneficial. I'm going to step you through some, but not all of those domains. And we've expressed this here as box whisker plots, and unfortunately lost the vertical axis there. But the interquartile ranges fall within that plot, and then you've got outliers in the bars, with the median being the X. So really, there was a tight clustering here, and I cannot read the top section of this slide, but this is confidence around would I have the skills to recognise deterioration if it was happening. And really, they didn't feel they could recognise it very well, and then it greatly improved. This next confidence element is, would I have the skills to initiate initial treatment? And again, we're showing a substantial difference here in initiating substantial treatment. And then this is kind of scary. This is sort of the inverse question. If I was called to an acutely ill patient, I'm worried I would do the wrong thing. Most of them agreed or strongly agreed to start with. And we improved that confidence a bit, but not a lot. And really, I suspect that's probably an optimum degree of improvement. You don't want them being overconfident, but we certainly have a long way to go in improving off a baseline where virtually every junior doctor thinks that they're going to do the wrong thing. And then I think this is a really important comment as well, that really in the time that we'd had them, they went from not at all really agreeing that they had the knowledge or skills to be an intern to feeling like they were beginning to be ready. And so this sort of simple intervention was reaping substantial results in confidence change. So we asked them to evaluate the program overall and the different components, and they said that the best bit really was the shadowing of the MET-Reg. That's great to know that that's really what we're aiming for, and that getting involved in case discussions and hearing their own discussion presented and the issues around it, as well as that of their peers, was really helpful to them. The less good bit was the surgical crit care fellow, and that's good, we were getting rid of that anyway. We rolled them up into becoming a senior registrar, where they were much more beneficial to us in the department. And so in terms of the evaluation of the program, well, they loved it, or all except the surgical fellow bit, and they thought that it was really applicable. And these are agreement scores out of 5, and so they were really happy with it. Now, that's not a hugely important marker of should we be doing this education, but it is certainly important to those delivering it. And I think this sums it up nicely. The qualitative comments were fabulous. And wanting to have it every year, wanting to have it more often, and really making it available to get a real sense that the demand was there and that they were very appreciative of it was very gratifying. So it is feasible to deliver programs such as this. We can do it where it's not feasible to follow them up into the intern year, I can guarantee that. Knowledge, we actually don't make a great deal of difference. So they've got strong baseline knowledge, but what they're lacking is confidence. And that immersion and embedding them in the team really boosts their confidence, and it, I think, is very gratifying, not just for individuals, but for those of us running the program. So I'd say that the strengths of our study were that we did this in a really mature MET system. We've been doing this for more than 10 years, in terms of running METs, that is. We had a high volume of METs, 2,500 a year at the time, and now over 3,000. We've got really expert nurses and junior medical staff in teaching and training. And amongst the consultant group, we also had existing educational expertise, and we're happy to use it. I suppose the limitations are, there was only a few of us, we were investigator-driven, we wanted this to work, and we were going to damn well make it work. And really, I'm not sure that we can rely on there being a clear correlation between self-reported confidence and quality of clinical care. And they probably learnt some other stuff in their final semester as well, and that may well be a confounder for their increasing confidence. So we really don't know what the optimum training model for MET is, and when we surveyed this group a couple of years ago at this conference, really we agreed that it needs further development, but we wanted to focus on teams. and that there are really some small simulated studies in the literature, but they're all about simulation. They're about sick mannequins, not about sick humans. And so actually embedding students in teams seems to be a novel way of exposing them to these clinical events. And I absolutely would ask that could this be something that's applicable to crit care nurses, to nurse practitioners, to physios, to anyone that's got an active involvement in a rapid response team. So I would highlight to you that medical students are a great captive audience and you don't need to backfill them. It is absolutely possible to capture their hearts and minds early on and we can do that efficiently and pragmatically without too much of our own time, and they're keen. And finally, I would suggest to you that decreasing terror is something we have a responsibility to do and that boosting confidence is an absolutely meaningful outcome for us as ongoing teachers and clinicians. And it's really rewarding. It is an absolutely rich learning environment with already fabulous teaching staff in it, and getting just the Goldilocks amount of confidence is right. Not too much, certainly not overconfident, but not too little either, and you can do it. And we're very happy to help any other teams that want to try and do this. Thanks very much.